in their lungs and all that kind of thing, it's not part of the protocol. You have to do oral care with chlorhexidine every 2 hours on these patients. Suctioning apparatus, tubings that go to your oxygen machines, all that kind of stuff is supposed to be changed every 24 hours. And then of course we're going to culture the patient, because that's something that's new. We're going to culture the sputum, see what they have, what grows out, and then they're going to get antibiotics as well. But the issue is that that's a big deal as far as monitoring purposes for core measures, all that kind of thing. Ventilator-associated pneumonia is a big one. So you'll see when you go to your progressive care units or your ICU units where you have patients that are on ventilators, you're going to see a lot of stuff in the room, and it's mainly because they have to kind of do this to make sure they're charting to this so that they don't end up eating costs associated with that patient. Then the last one up here is Legionella, which is a bacteria that primarily exists in moisture. Okay. Now the thing about it is this is something that we had a lot, but then we had an outbreak of a whole bunch of people got sick at one time. And so that's why this bacteria was now called Legionella. You know why? It's a whole group of old guys in Philadelphia that were at a convention. They were Legionnaires. All right? So they ended up getting sick. The people that died, of course, were old men who had chronic health conditions. So it is something that exists. And when they found it, because what ends up happening when you see weird stuff happening, because like with hantavirus and all that kind of stuff, the CDC goes around and says, hey, let's try to figure out why this is happening, what's going on, why these people have that. They figured out that it was coming from the air conditioning system. So it was a bacteria that normally exists in the environment, got into the hotel air conditioning system, was in this room where these guys were meeting, they inhaled it and got sick. So that's what ended up happening. So you see, we don't see it very often, you know, because now we would have to, and the thing about it is they did changes as far as buildings and that kind of thing that kind of address this issue. So it's rare to see somebody with Legionella anymore. That was the outbreak, and we never saw a big outbreak of it again, but it was something that had to be investigated, because we have to. Okay. The drug that we use for this one is erythromycin. It's a drug of choice, because it works really well for patients who have Legionella. But the pneumonia symptoms are pretty much the same that you're going to see with any other type of pneumonia. Temp, coughing, changes in lungs that they actually see the pneumonia on x-ray. Hypoxia, because remember, if the lungs can't or their alveoli don't open up, O2s are going to go down. So O2 saturation is going to decrease. PaO2 levels, when you do them on ABGs, are going to decrease. Those will be things that you see in the patient. So those will be sometimes those issues that you worry about that happen with your patient. Okay, so those are the pneumonias. The other thing that we see in that category on that first side is SARS. And like I said, that's not going to be on your exam. But SARS is also an infectious disease. That tends to happen endemically, meaning that you see it happen, and you'll see it happen in a whole lot of people in one little prescribed area. Okay. One of the things they saw it highly associated with was birds. Remember when the whole country, not just our country, but countries all over the world, was kind of worried about avian flu. That's what we were worried about. And you saw a high incidence of patients actually having SARS in Southeast Asia, China. Then we had a few cases in Canada, because Canada had a big outbreak, probably about 400 patients. And then we had a few in the United States. They were kind of scattered. And when you looked at their travel history, all of them had been to either Southeast Asia or the Philippines. I actually worked with a nurse at UT. Her niece actually had SARS and died. Never had any other stuff wrong with her except she was exposed to SARS and died. So it is something that is primarily, when it is fatal, has to do with somebody who does have some immune disorder or something going on, but you don't see it happen a lot. So it's one of those things that no matter when you are taking care of this patient, they go on respiratory droplet isolation kind of thing. But I don't ask you questions on that because you don't see it that often. They're going to ask you more on NCLEX, also in the class, about what you see in real life. So out of these, HAP and CAP, you need to make sure you know. VAP, you got to know because that's a issue with patients who have the whole issue about reimbursement kind of thing. Same kind of stuff you see in the patient, but I want you to go to the CDC website and look up the bundle for that one. And then out of these PCP, you may see a question on this that might be medication related. So I think I would remember that because you might see it again like in a few weeks. All right? Because it doesn't happen that often, but knowing the antibiotic may be something that you can see for credit, I don't know, kind of thing. PCP patients, of course, we do see a lot of patients who have HIV, but just kind of know the routine. It's not going to happen in everybody, immunosuppressed or HIV patient, and then think about the things we're going to do as preventative. Think about the signs and symptoms you see with the PCP patient. Dry hacking cough, high temp, hypoxic. Those are kind of things that give it away. Wet sounding lungs, but they're still not producing sputum. All these other ones produce stuff that make you want to gag and fall out and die, kind of thing. SARS is a yada yada. Because yeah, we got to talk about it, but that's not something you're going to be tested on. Now, that next section is where your big pieces of thinking about what happens with your patient. And we're going to see movies on these tomorrow as well. Because you're going to talk about ARDS and respiratory failure. Those you got to know. So make a star for yourself about what you're going to be seeing with your patients, what you're going to be thinking about what's going on with the person, that kind of thing. All right? When you read them in your textbook, they're going to sound just alike. So you know what you got to do, right? Figure out what makes them different. Okay? So we talk about this one being acute. That's one of the things to think about. This one is something that's generally happening with a person who has some type of acute illness or trauma. So if you're reading a question that says this patient getting blood transfusion, or they run a car accident, and now they're having respiratory distress, it may be this one. All right? Because what could it also be? Because we got traumas in there, remember? So you got to think about it. But when you're thinking about a person that has hypoxia, because these people, both of these, no matter what, have what we call refractory hypoxia. That means no matter what I do, the patient's still hypoxic. I'm treating them. Refractory means I've treated you, doing all the best things I can do, and you're still hypoxic. So refractory means not responding to treatments that I do for my patients. These patients on both sides have that. Okay, so you're going to see that when you're reading it, go like, oh, both these patients are hypoxic. How do I figure out the difference? Whether it's hypoxic failure or hypercapnic failure makes no difference. Because that's the first thing you're going to do. Oh my God, it's both sides on this. Patient's dead, whether it's hypoxic or hypercapnic. What you have to do is correct the problem. Okay, so that, people get into that and that's not the thing to worry about. What are you going to do for the patient because they have the problem? So refractory hypoxia is what you're going to see on both of these. So then I have to think about what makes them different. So ARDS, acute respiratory distress syndrome, acute problem. So that's something that's sudden onset. That's how you think about it. Something acutely is happening with this patient. And the reason you say that is because it can go all over the place as far as what the causes are. Trauma patient, person who was in a fire, because that's not something you normally do, so yeah, I'm inhaling stuff, okay? Can also be from pancreatitis. An acute pancreatitis can cause the patient to have ARDS. So think about acute onset of things that patients have can cause the problem in the patient. Severe hypoxia is what I'm going to see in the patient, okay? Now that's going to happen with the respiratory failure patient too, but think about chronic disease primarily is where you see it happen in patients. Now don't get me wrong, you know how it's always somebody that's not in the box, right? Some fool always messes it up. All right, so it's all, think about chronic patients. So this is your asthmatic, poorly controlled. COPD, who's poorly controlled. Those are people you see that most often in. Patients have chronic lung disease, bronchiectasis. Cystic fibrosis. So think about things that are chronic in nature is the respiratory failure side. But guess what? Still going to have refractory hypoxia because that's the major component you see between both. So that's why I said when you start reading the stuff that's in your textbook, they're going to sound a lot alike. Think about acute onset here, chronic disease that I see happen here. Okay. The other thing that makes it different is that there's a change in the lungs here. Does not happen on the other side. And you're going to see a video about this tomorrow. Mainly because that's the one thing that you go like, oh my gosh, this is why it takes so long to resolve. Both of them are bad. And when you start seeing a patient who's been ventilated going on that third week, that's when the doctors say, should we put in something more permanent as far as airway management? Because you put an ET tube in, it's not meant to be there forever. So after about 3 weeks, this person's still not getting better, that's when we start talking about, do I need to put a trach in this patient? Maybe earlier, depending on what's going on, but most of the time you give them about that 3-week period of time. Because that's what generally happens. This one has a course that you see that happens with your patient. What we try to do is minimize that course from happening. But there's a physical change that happens in the lung tissue itself. There is a hyaline sheath that builds around the alveoli that doesn't let them stretch open. Okay, so the alveoli are supposed to open and close, right? You take a deep breath, they compress, you've got to bring them in, breathe out, that kind of thing, but they actually recoil and open. All right? What happens when you have a person who has ARDS is that instead of being able to open fully, there's like this hyaline membrane sheath that develops around the alveoli that don't let them open. So when that happens, remember, when you take a deep breath, what happens to your O2 level? It goes up because you're aerating the alveoli. So if they can't stretch open, hypoxia is going to continue. So one of the things that you see as far as treatment of this person, now remember they're refractory hypoxia. This means they can no longer support oxygenation of the body. What do they always get? You're going to get O2 first, but if they can't do it, what am I going to do for them? Because remember they've been...
Intubate them?
That's intubation. So that's the thing that kind of fits with these two. Because this person, I tried them on a, cannula. We went kind of through this. Put them on a mask. O2 still doesn't go up. I'm going to put them on a rebreather mask first. And a rebreather mask has those little gadgets you put on to close them off. If you can't get a person up, they're still hypoxic when you're doing that. Total non-rebreather, you make sure that the bag is distended before you put it on the patient. Have both of your valves covered. If that person's still hypoxic, that's the person who needs to have some type of artificial airway placed. Okay, so hypoxia, I give them all that I can. When you do a non-rebreather mask, that's the closest to 100% O2 you can do without intubating the patient. You do about 99% when you talk about a non-rebreather. Okay, so if that person's still hypoxic, if I still got an O2 level in the 60s, 60 you need just minimum to live. That's you laying in a bed, not even opening your eyes. Doing the minimum just means breathing. But if you open your eye, you need more oxygen. If you move your leg, you need more oxygen. So if a person is below 60, very bad thing, all right? So that means I'm going to have to put in an artificial airway for this person. So the usual thing is an ET tube, endotracheal tube we put in the patient. Then we put them on a ventilator with 100% O2. Then we see if their numbers go up. Because guess what? Sometimes you can do that and the patient's still refractory. That's a very bad patient. Then you start doing crazy stuff. All right, you intubate this patient, and let me go over this part first. So changing the lungs so they get a hyaline membrane sheath.
There's a nice diagram of 60 and 66 in the textbook.
There's interstitial edema. What do you think that's going to produce in the patient?
Mucus.
It's going to produce mucus, but also crackles when you listen to their lungs. Okay, so you see interstitial edema.
Isn't there any meds to remove that membrane that forms?
Are we going to talk about it?
Oh,
Because there's something you got to do to try to treat it in the patient. That's why I was like, I stopped myself, because that's a complication thing. All right? So we have interstitial edema, and we also have inflammation. Now the reason I put those there, because guess what you might give to this person?
steroid.
Steroids. All right? Because this is inflammatory process is producing this edema. So part of what you may end up giving to a patient who has ARDS are steroids. They are not the first line thing you do for a patient who has respiratory failure. Now you may give it because of their disease process, but you see it a lot here because there's inflammation that's there. I need to get that under control with the patient. Okay, so steroids might be given here. Now because I have these alveoli that are not opening, because remember, alveoli are something that's supposed to open and close. What is that substance that they have to have that makes them so much easier to open? Surfactant. So if I can't produce that, then that's going to make them even more airless. Okay, so I need to stretch them out. Okay, so when the person is on a ventilator, I'm going to actually push air into the lungs at the end of expiration. So that's positive end expiratory pressure, or P.
I don't know all the values of those.
No. Now, if you work in ICU, you need to know all that.
Yes, yes.
You know what the overall treatment is? P, positive end expiratory pressure. This means I put you on a ventilator. I'm going to say what your tidal volume is, like 750 or 1,000. That's how much I want to actually push in your lungs at each breath. Remember that tidal volume, right? That's the amount of air you take in with each breath. So I'm going to put this person on 750 of tidal volume, and then I want to do P, a +1 or +2, usually what we see on a patient. But what that does is at the end of expiration, means that once you send everything out, I'm going to push air into your lungs. What that's going to do is make the alveoli stretch. Same process by what you, it's the same thing essentially that you're doing when you got a patient who's using a center spirometer. You know how you have them, because they think they're supposed to, I'm supposed to breathe in. I'm like, that's not working. I mean, I breathe out, blowing air into it. But when they pull the air in, what happens? They'll tell you, oh, it's harder to do. It hurts because you're using it right. Now, you know, when they're just blowing into it, it doesn't hurt at all. All right? But when you're using it like it's supposed to, especially if you have pneumonia or you have chest surgery, that kind of thing, it's going to be a lot. So what that's going to do is actually push air into the lungs at the end of expiration, and what it does is make the alveoli stretch. So hopefully you limit the amount of membrane formation that's there. More surfactant is produced, so that's going to increase oxygenation, and it's also going to actually help it get better over time. So you may see a patient with severe ARDS not only get steroids, okay, they get surfactant along with it. Then if that doesn't work, because you know there's always somebody that's still not right, okay, and hopefully, this is bad for me to say this, but hopefully you'll see it while we're in the hospital. Because this is a patient that's not doing well, so that's why it's retarded for me to say such a thing. But there is a bed that you put a patient on, an ARDS bed, that turns the patient all the time. They look like they're in an iron lung machine. But why they do that is because if you lay a person on their stomach in prone position, it actually helps decrease some of the interstitial edema and the patient gets better. But do you know how hard it is to turn a patient over who has a ventilator to lay them on their stomach? So you have a bed that does it for you. Costs about $1,500 a day for the patient to be in the bed. But they're really neat. I know it's going, but it's so cool. And you usually see it if somebody's not getting better, and you'll see them on that. So when I've been to Florida Hospital for years now, but at least every semester there's one person that's on one of those beds. We got a lot of people that are doing it because, unfortunately, young people taking spice and they end up on ventilators and they're not getting better. So that's the last-ditch effort. They're trying to see if they can oxygenate kids and stuff. So you'll see that. So positive end expiratory pressure is something you see associated with ARDS. You don't see it as much, you don't need as much pressure support with a respiratory failure patient. But you do need it with the ARDS because you need to open up those alveoli. Now the complication associated with that is if I put too much air in, I can actually rupture the alveoli. So that's the patient who has subcutaneous air. Feels like Rice Krispies under the skin, and you'll actually feel it. You know, when you put your hands there, you leave your fingerprints in the person's chest. You're like, oh, maybe we shouldn't do that. That's called barotrauma. It's also what it's known as. Okay, but they've actually ruptured the alveoli in the patient. So you may see that happen. Okay, so acute onset of symptoms, hyaline membrane that happens around the alveoli, there's interstitial edema, inflammation that happens there. Patients will require some type of intubation. And one of the things that even though we put in intubation because we want the patient oxygenated, remember you pass by all the things that keep your airways safe. So VAP is one of the things that can happen with this one, but also, you know, that whole thing about infection, macrophages, all that kind of stuff that your body protects itself. The airway, you have issues with that because you're going past all those things. So patients can aspirate, all that kind of stuff. So you have to be careful about when you have a patient on a ventilator. For my chronic patient, one of the things that you also have to consider when you talk about patients who have chronic respiratory disorders, remember their hypoxic drive is different from somebody who has normal blood gases. These patients are very hard to wean once you put them on a ventilator. So patients who have asthma, poorly controlled bronchitis, CF, you really have to make a conscious decision about whether you want to have them, because you are not going to be a person that we tube you and you get off. You're going to be a person that is tubed and likely have a trach for the rest of whatever life you have. So sometimes you'll see doctors actually talk to patients about what you want done. Because this is not a person that, you know how we fix things all the time, you're not always able to fix stuff. And people who come in the hospital talking to you, remember when you have a trach, you can't talk. These people can't because they'll never be the person you can plug. This is a person that's always going to need a ventilator all the time. So do you have a person, you know, and you have people of all ages with all different things, what quality of life is that for the person? So sometimes you have to talk to people about that. And it's sad, but that's the truth of it. Because these people you don't always get off. Especially COPDers. They tend to be the group that you don't get off more than anybody. And you'll see, I've seen doctors actually come in and talk to the person at the bedside and say, do you really want this done? PaCO2 is like 80. What's the normal?
35.
35 to 45?
35 to 45. Patient is 80.
Oh my God, that's a lot of carbon dioxide.
Because they're retainers. That's chronic disease that you see in a patient. You put a person like that on a ventilator, you ain't getting them off. That's, you already saying this is a person that's now going to go to, you don't call it Vancouver anymore. What's the name of the hospital? Kendrick. That may have been up walking around before, but now they have a ventilator all the time. So those are things you have to, those are things that have to be considered in those patients. But these are the worst case scenarios when you talk about patients who have respiratory disorders. Refractory hypoxia is key. And you're going to see a lot of the same signs and symptoms when you read the textbook. But remember, ARDS, acute onset of symptoms, acute problem the patient has, there's a physical change that happens in the lungs. You're not seeing that in a respiratory failure patient at all. Okay. All right. Y'all want to take a break?
Yeah.
Sure.
All right.